Hi friends, today I will talk about ECG changes in hypokalemia. First is the disclaimer. Caring Docs YouTube channel does not provide medical advice. Information available on this channel does not offer diagnosis or advice regarding the treatment. Information provided by this channel is for educational purpose. It should not be used as an alternative to healthcare professionals' diagnosis or treatment of any person or animal. Please seek the help of medical expert for diagnosis, prevention, and treatment of medical illnesses. There is no endorsement for any brand or a company. Hypokalemia is defined as when the serum potassium level is less than 3.5 millimole per liter, or we can say less than 3.5 milliequivalent per liter. ECG changes do not manifest until there is a moderate degree of hypokalemia, that is, when the serum potassium is in between 2.5 to 2.9 milliequivalent per liter. The earliest ECG manifestation of hypokalemia is a decrease in T wave amplitude. So, the ECG features of hypokalemia are usually seen when the serum potassium level is less than 2.7 milliequivalent per liter, and these ECG changes are increased P wave amplitude, prolongation of PR interval, widespread ST depression and T wave flattening or inversion, prominent U wave. These are best seen in precordial leads V2 to V3, and there can be apparent long QT interval due to fusion of T and U waves, or we can say long QU interval. With worsening hypokalemia, we can also see frequent supraventricular and ventricular ectopics. The supraventricular tachyarrhythmias like atrial fibrillation, atrial flutter, atrial tachycardia can be seen, and patient can develop life-threatening ventricular arrhythmias like VT, ventricular tachycardia, ventricular fibrillation, and Torsades de Pointes. In this CCG, we can see T wave inversion and prominent U waves. Here we can see apparent prolongation of QT interval, or we can say QU interval. So there is apparent ceto prolonged QT interval with an absent T wave. The push and pull effect I have already discussed in ECG changes in hyperkalemia. Here in hypokalemia, there is a illusion that T wave is pushed down with the resultant T wave flattening or inversion, ST depression, and prominent U waves. In hyperkalemia, T wave is pulled upward, creating tall dented T waves and stretching the remainder of the ECG to cause P wave flattening and PR prolongation and QRS widening. The pathophysiology behind the hypokalemia is potassium is vital for regulating the normal electrical activity of the heart. Decreased extracellular potassium causes myocardial hyperexcitability with the potential to develop reentrant arrhythmias. So, as we know that hypokalemia is the most common electrolyte abnormality in hospitalized patients. It is mostly caused by the drugs and the GI diseases. Potassium is the most abundant cation of the body. 2% of the total body potassium is found in the extracellular space, and potassium homeostasis largely is regulated by kidneys. That is, kidneys contribute about 90% of the daily potassium loss, and the rest potassium is eliminated by GI tract. Normal potassium level is between 3.5 to 5 millimole per liter. Hypokalemia can be defined as mild, moderate, and severe. Mild is when serum potassium is level between 3 to 3.5 milliequivalent per liter. Moderate when it is between 2.5 to 3 milliequivalent per liter. And severe it is when it is less than 2.5 milliequivalent per liter. The upper GI causes of Hypokalemia or vomiting, mid GI causes are fistula, lower GI causes are diarrhea, and other causes like sweats, burns, bleeding, renal replacement therapy can also contribute to hypokalemia. In nutshell, we can categorize the causes of potassium loss as decreased potassium intake, poor dietary intake, starvation. Whenever there is magnesium depletion, there is it increases the renal potassium loss because of poor diet, increased magnesium loss. Patients who have mineralocorticoid excess, primary aldosteronism, Cushing syndrome, accelerated hypertension, renal vascular hypertension, renin producing tumor, adrenogenital syndrome, licorice excess, Bartlett syndrome, Lydia syndrome, all they contribute to hypokalemia. The increased losses are also seen with the drugs like diuretics, laxatives, steroids, antibiotics like carbapenems, gentamicin, amphotericin B. Potassium is also lost through skin by profuse sweating, extensive burn. GI lyses are diarrhea, vomiting, ileostomy, intestinal fistula. Renal causes are tubular disorders, nephrogenic diabetes insipidus, and various other syndromes. Endocrine causes are hyperaldosteronism, Cushing disease, Conn syndrome, dialysis, which when there is dialysate with low potassium, that also contribute to hypokalemia. Peritoneal dialysis also contribute to hypokalemia. Whenever there is transcellular shift, for example, when we give insulin glucose therapy, we give beta agonist alkalosis, respiratory and metabolic alkalosis, hypokalemic periodic paralysis, all they contribute to hypokalemia. I will have another video on this management of hypokalemia. This is just a nutshell. The patients of hypokalemia may not have any symptoms. When symptoms are present, they may present with fatigue, muscle cramps, weakness, constipation, rhabdomyolysis, ascending paralysis, respiratory failure, arrhythmias. Symptoms more likely in pre-existing heart disease. There are certain medication which causes hypokalemia I have already discussed. Sotalol also increases the risk of arrhythmias. So the patient will have instability, will have arrhythmias in ECG. Neurological examination will show weakness, motor sensory loss. So we should always investigate. When we are investigating, we have to measure the serum potassium level, magnesium level, calcium level, phosphate level. ECG is will give us U waves, T wave, flattening, resting depression. Um, with progressive worsening, we can have VT, VF, long QT syndrome, and Torsades Pointes. Patients who are on digoxin, we should do their digoxin level. So, hypokalemia is described as mild, moderate, severe, mild when serum potassium is in between 3 to 3.4. Moderate is when it is between 2.5 to 2.9, and severe is when it is less than equal to 2.4. So, whenever the patient of hypokalemia is suspected, we should always think of hypomagnesemia also, because hypokalemia is often associated with hypomagnesemia, which increases the risk of malignant ventricular arrhythmias. We should always check both potassium and magnesium levels in any patient with arrhythmias, and we should replace potassium to more than equal to 4 milliequivalent per liter and magnesium to more than uh, 1 milliequivalent per liter to stabilize the myocardium and protect against the arrhythmias. This is a standard practice which is followed in most CCUs and ICUs. So this ECG shows widespread ST depression and T wave inversion. We can see prominent U waves, long QU interval, and this patient had a serum potassium level of 1.7. Similarly, in this ECG, we can see ST depression, T wave inversion. They are best noted in lead to 3 AVF inferior leads, prominent U waves, long QU interval. In this patient, serum potassium was 1.9 milliequivalent per liter. Here we can see the hypokalemia causing the Torsades de Pointes. Here we can see atrial ectopics causing R on T phenomena, or we can say R on U, because this initiates the paroxysm of Torsades de Pointes. Management is always we have to replace the magnesium as to facilitate more rapid correction of hypokalemia. When there is no acute situation, we can give potassium as 10 to 20 millimole per hour. Whenever there are life-threatening arrhythmias, we should always give potassium as 20 millimole or milliequivalent over 10 minutes, and magnesium as 10 millimole over 10 minutes. Walt Whitman has said, "The secret of being is not only to live but to serve." With this, I conclude my today's topic. Thank you. Keep learning.